New cutting-edge procedure that actually implants a new heart valve while the heart is still beating. It is remarkable. We wanted to find out just how this operation works. Tonight, Matt is live from St. Joseph's Hospital with an exclusive look inside the operating room and how this cutting-edge new procedure actually works. Matt.
Well, Megan, you know, as we get older, our hearts do age and the valves in the heart do stiffen over time. In fact, the aortic valve is one of those that takes place. Now, if you're a little bit younger, at least relatively younger and somewhat healthy, a cardiac surgeon can go into the heart and then replace that valve for you. But if you're older and you have other illnesses that are part of your health picture, you haven't had any other options. That is until now.
But you can come right in.
This high-tech world is a hybrid operating room.
All right, y'all ready for a little valvuloplasty here?
Sorry? Yeah. Get ready to do a valvuloplasty.
Okay. Pacer on, please.
Interventional cardiologist Dr. Ron Caputo stands side by side with cardiac surgeon Dr. Randy Green.
Randy, what do you think? If I come a little more this way, take one more picture.
State-of-the-art innovation in catheters, heart valves, and real-time imaging gives this collaborative team the tools it needs.
A little test. A little deep. Not much, though, because it's going to rise up.
They are implanting a new aortic valve without cutting open the patient's chest. This is one of 4 teams across upstate New York offering the TAVR procedure to patients who could not withstand surgery.
Yeah, a lot of these patients are like that. They ratchet it down, they feel bad, so they just stop, slowly stop doing stuff.
TAVR stands for transcatheter aortic valve replacement. Ideally, the catheter is threaded through the femoral artery in the groin.
They go up through the sheath into the abdominal aorta, and we have to get these balloon markers to line up on the valve. So the
Pat Romeo is with Edwards Life Sciences, the company that makes the valve and its delivery system.
Using this handle, they will actually put a curve into the catheter that mimics the shape of the aorta. It will come down through the aorta, cross the annulus.
The physician gets it in the correct spot, determined on angiography. They'll inflate the balloon, and that old calcified valve will help stabilize the TAVR valve in the right location.
Lucy Schluter is the TAVR coordinator at St. Joe's.
And the leaflets, the tri-leaflets of the valve, work instantaneously. And
so nothing's sewn in, nothing?
Nothing's sewn in. Yeah. It's this stent-like technology that keeps everything kind of locked into that calcium.
What's that all made of in there?
This is a cobalt chromium.
That provides the solid base for the valve made from cow tissue. The metal mesh is also flexible enough to be crimped to a small enough size to pass through the arteries before the balloon restores it to full size as the new aortic valve.
They just get up faster and they get out quicker, and they do better if you can do it through the groin.
The team walks through the patient's particulars, history, medications, and critical pre-procedure imaging. The only patients eligible for a TAVR procedure have too high of a risk for surgery. Our patient had a previous bypass. He's 86 years old. Knowing every detail matters to ensure a successful outcome.
And we have blood. Okay. Everybody's good? Let's go.
A room that starts with casual chatter, quiets, focuses, and fills with tension as the stakes rise.
So I think we should pace and make sure that everything's still before we... Y'all ready?
There's no heart-lung machine assisting. To deploy the new valve, the team forces the heart to beat so fast, it stops. Blood flow halts. The concern arises. Will life return?
Hammer it now. 1, 2, 3, 4, 5, down. Pacer off, please. Okay, pacer off, please. Yeah, let's shock him, please.
Now, right at that instant, the heart has stopped. Coming up tonight at 6, we'll tell you what the cardiac team did to get that heart beating once again with this patient that now has that new TAVR valve inside of him. That's all coming up tonight at 6. Megan?
That is just incredible to see, Matt. And you can feel the tension, the anxiety in the room, but clearly these folks know exactly what they're doing.
Yes, they're a very accomplished team. They work well together. They're really, truly ready to handle any eventuality in that operating room.
A remarkable team. Great to see, Matt. We'll see you again tonight at 6. It is part 2 of our exclusive look at a remarkable heart procedure that gives patients a new heart valve without any surgery. Tensions build as doctors revive a patient after they purposely stopped the beating of his heart during that procedure, a moment that is sure to leave you on the edge of your seat. Our exclusive inside look at this cutting-edge new heart procedure continues tonight as Matt joins us from live inside the operating room at St. Joseph's Hospital. Matt?
Well, Megan, earlier on NBC3 News at 5:30, we took you inside the operating room, and when we left, the cardiac team had just stopped the patient's heart from beating. Just at that moment, that's when they need to deploy that valve. Let's head back into the OR and show us how they made it up to that moment.
For a percutaneous left femoral TAVR procedure with a number 29 sapien valve.
The TAVR team gets to work. 1 minute into the procedure, cardiologist Dr. Ron Caputo raises concern about the patient's low heart rate.
Why is this heart rate in the 30s?
The incision is made in the left groin area. Passing the catheter can get bumpy. Calcification gets in the way in the 86-year-old patient.
It's very, very crunchy artery.
The team prepares the way to introduce the new valve. Again, concern about the low pulse.
Why is his heart rate in the 30s when we started? He's in flutter, so he might need a pacer before he goes home, you know.
The Edwards sapien valve is rinsed, then crimped onto the delivery catheter. It must be small enough to pass through the aorta before being positioned and inflated. Several sets of eyes interpret the angiography.
This is the skirt, and
This is proximal toward the ventricle.
yes, yep, the leaflets are here.
Okay, all right, so we're okay. It's good to check that.
Have lights off again, please.
They test the position with dye. The patient's cardiac rhythm continues to struggle.
Now let me just get this up here, reorient it, and load the valve.
Dr. Caputo stands with cardiac surgeon Dr. Randy Green. Tension builds. It's time to speed up the heart rate, forcing it to stop for the instant needed to deploy the valve.
All right, let's do it. You all ready? Your lungs are still down?
Yep.
Pacer on. Okay. Inject. Go up.
Hold on.
Take that. Hammer it now. 1, 2, 3, 4, 5, down. Pacer off, please. Okay, pacer off, please. Yeah, let's shock him, please.
Everybody clear. Charge. Go ahead, hit it.
Yep. Get ready with the pacer, please.
60.
Pace at 60.
Don't plug it in yet. Yeah.
You want to?
Yes.
Yeah, pace it now at 60. He's coming back.
Okay. Sergeant, he may need a little neo.
Let me get this out of the valve. Huh?
The gravity of the moment passes. A transesophageal echo indicates the valve is properly seated. The new leaflets have taken the place of the old.
It's calming down nicely. All right, good.
Describe for me that moment then, leading up to that. Where are you in the procedure and kind of what happened and how'd you get out of it?
We want everything to be very still, so there's no motion. We actually have to pace his heart so fast it stops. And so for that period of time, there's no cardiac output, there's no blood flow. And, although it's really only a matter of a few seconds, for us it seems like about 10 years while that's happening.
So what did you do today to handle that and get everything back on course?
Well, the first issue is recognizing that the patient has a rhythm that's inconsistent with life. Cardiovert the patient into a rhythm that perfuses and resuscitate him with medication. As you saw, our anesthesiologist plays a major role in that, having the right medicines drawn up, responding quickly. The longer that period lasts, obviously, the greater the risk to the patient.
Seems to me that was an instance where we talked about the team idea.
All right.
The team ends up being,
You got it.
makes all the sense in the world.
Absolutely,
You know, having both of your skills and everybody else in the room, would you agree that that's
Absolutely. It's always good to have somebody, you know, to run things by, and you know, two ideas is better than one. And you know, sometimes Randy comes up with something great, sometimes I do. But yeah, definitely a team approach is helpful.
Yeah.
And joining me now here live is interventional cardiologist Dr. Ron Caputo, and we are talking in the piece about the team concept. This is really a big change in the way cardiologists and cardiac surgeons work side by side, but it's working for you very well, isn't it?
It's really working well. Took a little getting used to, as you can imagine. A lot of personalities in the room, but I think it's been one of the really nice aspects of getting this program going together. I think we appreciate what each other really does during the course of a day, and I think we complement each other.
What are some of the risks? You know, we showed a positive outcome here, but there are a lot of risks for the patient here, aren't there?
There are a lot of risks. These patients are, in general, elderly and have multiple other medical problems, so they're at risk anyway. And the things we worry the most about really are vascular problems from the site of entry. There can be some bleeding and so forth. The artery might not heal exactly the way you want it to. The other risk that we worry about is stroke. There's a small chance that a patient could have a stroke. Heart attack, less so. And then just sort of all the other things that might go along with the person through anesthesia and so forth.
With regard to TAVR as a procedure and a technique, where is it going from here? Will there be further developments that will make this better and more useful for other purposes?
Yeah, I think that we've already seen some really exciting developments. The equipment's getting better. We're getting some adjunctive equipment to help us with the holes and the arteries and so forth. Just better devices, easier to deliver. I think that eventually we will be able to apply this technique and technology to an even broader patient base. More patients might be eligible for it.
Dr. Caputo, thanks very much. Fascinating to be in the hybrid operating room. Dr. Randy Green, the cardiac surgeon of the piece, was not able to be here tonight. Otherwise, we would have been talking with both sides of this cardiac team. Megan, a fascinating view inside the operating room live here from St. Joseph's Hospital.
Clearly a very capable team, Matt, and our thanks to them for that incredible access inside the OR.